Good evening, dear friends. In this presentation, we will discuss some aspects of interpretation of CGMS. After a brief theoretical introduction, we'll go through what are the currently available CGM devices in India, important points amongst the guidelines on CGM reporting, different components of a CGM report, how to interpret, what are the steps in interpretation of CGMS, and to illustrate that, we'll take help of few of the cases. Now, many of us know that continuous glucose monitoring system measures interstitial glucose, which typically lags behind by a period of 5 to 15 minutes compared to blood glucose. This lag period may be different as in different devices, and also if the blood glucose, whether they are stable or whether they are going up or down. The CGM can be real time, which means that the user is able to see the values, glucose values in real time and act upon them. Or it can be professional, which is basically blinded while the period of use, and it's only downloaded after that particular 7 or 14-day period of use. And the most popular device in the past few years has been intermittently scanned, or a flash libre device, where you just flash the reader across the sensor and it shows the glucose values. Now, studies have shown that sustained use of real-time CGM is associated with reduction of severe hypoglycemia, improvement of HbA1c, and reduction of glycemic variability. And some of the newer devices like Dexcom G6, the Freestyle Libre, and Senseonics Eversense are approved for use as replacement for blood glucose. Although in my practice, I'm still using SMBG with the help of a glucometer to confirm low and high values while using Freestyle Libre, because many patients have reported some variation with respect to particularly the low and high values. This is the data from the Type 1 Diabetes Exchange Registry of about 17,000 participants, where it was clearly shown that those people who use CGM, either along with the basal bolus therapy, as shown in the black boxes here, or with insulin pump, as shown in the white boxes, typically across all the age groups, have better HbA1cs as compared to those who don't use CGM. Remember that largely, again, even here also, the sustained use is what is more important. So currently, the CGM devices that are available in India include Medtronic iPro 2 Professional CGM. Libre Pro was available for quite some time now, and this year Libre 2 is also now available, which is available for use by the people with diabetes. Dexcom has been intermittently available, the G4 one. G6 is not available in India. And Medtronic has their real-time CGM, that is Guardian Connect, which can either be used as a standalone CGM or can be integrated with the insulin pump. The long-lasting CGM that is used for 90 or 180 days, that is Eversense by Senseonics, is not available in India as of now. Now, there have been 2 or 3 guidelines with respect to CGM reporting by ATTD and ADA and ACE and many other societies. The common points in all these guidelines are that at least 70% of the data, that is at least 10 days of data out of the most recent 14 days, should be available. This is because it has implications for predicting outcomes over the next 3 months. The important parameters that should be available, or the important matrices that should be reported in a CGM, include mean glucose value and the value that is derived from mean glucose, that is glucose management indicator, GMI. It was previously also known as estimated A1C, but this term did cause some confusion with the laboratory HbA1c, and often people mistook that this can be an equivalent of laboratory A1C, and therefore it has been replaced with the new term GMI. There can be several measures of glycemic variability, but the one that has been very widely used and is recommended is the coefficient of variation. And the recommended percentage of coefficient of variation is less than 36% for most people with type 1 and type 2 diabetes. Then there are 5 matrices which are for time in, above, and below the range, which we will be discussing in the talk that follows my talk. And all CGM devices, irrespective of the manufacturer of the device, should report the outcome as an ambulatory glucose profile. The guidelines do also suggest a practical tip of having a single page report for easier review and filing in the electronic medical record. Now, this and a couple of more studies. This study was done over a period of 3 months on 185 subjects, and it was found that if we have data of 14 or 15 days, that data predicts the outcomes over a period of 3 months in terms of mean glucose and HbA1c in a better way, with a R-square value of about 0.7 in this study, and there's another study where the R-square value is 0.84. So that is the reason why 14 days of data is recommended to predict outcomes over the subsequent 3 months. This is a visual presentation of the different timing range targets, which will be discussed, as I said, in the subsequent talk. But the one key message here is that for most patients with type 1 diabetes, we must ensure that at least 70% of the readings are within the range of 70 to 180, and less than 4% readings less than 70, and less than 25% reading should be more than 180. Coming to the parts of the CGM report, there are 3 important parts of the CGM report. One is this AGP report summary, where we have the name and registration number, the identification of the patient, the dates in which the CGM was taken, and what percentage of time the CGM was active. And then there is different the matrices that we discussed: average glucose, GMI, and variability in terms of coefficient of variation. And we have timing range being presented numerically as well as in the graphical format. And we can see that in this particular patient, the timing range is about 47%. The second part of the CGM report is the actual AGP, or ambulatory glucose profile. Now, what is AGP basically? Previously, all of us have seen these kind of reports where the one worm or one line represents one day. Now, if we have too many lines, the data becomes too dense and it becomes difficult to interpret. So therefore, what AGP does, it collapses this 14 days or 7 days of data into smoothened curves, which show the median lines and the interquartile and interdecile range, as we will see in the next slide. So AGP basically has this dark blue line, which is the median glucose value, the interquartile range, which is represented by the dark blue shaded area here, and the interdecile range, which is represented by the light blue shaded area. So it takes care, it is showing 80% of the values. It is not showing the top 10% and bottom 10%, because the principle is that if we achieve this 80% within the desired range, we are likely to achieve our outcomes. Now, different companies give different display of AGP, but in principle, these 3 components will always be there. So on the left hand, you are seeing this report by Medtronic Guardian Connect. And here you can see that there are 2 sensors being reported, A and B, for 14 days each, 2 time periods basically. And this blue is A and the orange one is B. And again, the dotted line is the median, and the shaded colored area is the interquartile range, and the line without any color is the interdecile range. And we have a comparison of the older time period and the newer time period with respect to the timing range. So this gives a visual analysis of what the improvement has been. On the right side is the output through Dexcom CGM device. And you can see similar kind of output, just a change of colors basically. The third component of AGP, or third component of the CGM report, is the daily glucose curves. Now, whatever interpretation we make from the AGP, to analyze the causes of that, we need the help of daily glucose curves. And just having the curves is not enough. We need data on diet, exercise, and special situations to interpret the cause of these abnormal patterns. Also, we can compare weekdays versus weekends, or any special days like holidays or menstrual cycle, etc. Coming to the steps of interpretation of AGP. Like in any report, the first step is to identify patient correctly. If the patient has sent you multiple sensors, then we also need to identify the sensor number, which is usually written on the underside of the sensor, and check the dates, whether the dates are correct. Check for adequacy of data. As I said, that at least 10 days data should be available to make meaningful interpretation. In the AGP curves, mark insulin doses, meal timings, and any other comments that you want to, any other important comments. And also, because it's a visual interpretation, it also makes us easier to discuss with the patient what they see and what they think of their curves. After this, we identify patterns of low glucose and hypoglycemia risk, and then patterns of high glucose. Subsequently, we assess variability and stability of glucose, compare with previous report if any, and then make an action plan. As I said, that whatever patterns we observe, we use the daily curves to identify reasons behind those abnormal patterns. So let us take help of few of the case studies. This 14-year-old girl with diabetes of 5-year duration, type 1, without any comorbidities or complications. Her issues are consistently poor control, ranging with HbA1c ranging from 9 to 10 or 10.5, and in addition having hypoglycemia, inadequate SMBG, sometimes 1 or 2 readings a day, or sometimes even lesser than that. She weighs 50 kg. She is on basal bolus insulin with glargine and regular insulin with a dose of 1.24 unit per kg. Now this is her AG. As I said, the first step will always be to confirm the patient, confirm the dates, and see how much data is available. In this patient, 15-day data was available. Then we should also see that whether the target range is according to what we want. The default target range is usually 80 to 140, but for most patients, we keep a desired target of 70 to 180. For a few motivated patients who are doing extremely well, we can keep a tighter target range of 80 to 140 also. This we can modify when we are downloading the sensor. The report also shows the daily average blood glucose value and 2-hourly averages are displayed. So those who like numbers more than the figures, then we can see the 2-hourly averages in the top line. On this report, we should mark the meal timings. Here are the breakfast, lunch, and dinner timings, and also make any markings with respect to any other comments that we want to make. And then try and see. What I do is I visually break this curve into multiple portions, like overnight, pre-meal, and 2 to 4 hours post-meal. So this is how you can imagine, or you can try and analyze what is happening in these particular time periods. So if we see the overnight period, we see that there is a significant risk of hypoglycemia and hypoglycemia happening. The 25th percentile is below 70 and 50th is almost touching 70. We also see that the 25th percentile is reaching the hypoglycemia line in a delayed post-breakfast or just a pre-lunch time, and also somewhat in the post-dinner time. And there is a steep rise of blood glucose followed by steep fall after the breakfast. There is some high interdecile range in the afternoon time. So this, whenever we have high variation with respect to the interdecile range particularly, that suggests that on few of the days of observation, there was some variation with respect to diet or some other. So then we take the help of daily curves to understand this. We can see that there is a sustained pattern of low glucose in the night and the high glucose following breakfast, followed by a steep fall of the blood glucose. And on few days, there has been high sugars in that particular time of interest where the interdecile range was high. So when this is happening on few days, we don't need to change the baseline insulin dose for correcting this particular problem. But for the pattern of nighttime lows and the post-breakfast high, we might need to make adjustment to insulin dose or time. So what will be the most appropriate adjustment for this particular patient? Should we reduce bedtime glargine because she's having lows in the night? Should we reduce the dinner time regular insulin? Should we increase the breakfast regular insulin because there is a high glucose after breakfast? Should we adjust the time gap between regular insulin dose and the start of meal, or change to rapid or ultra rapid acting insulin? So as we see this, what I see is always we tackle hypoglycemia first before hyperglycemia. So we can see here that although the blood glucose is low in the night, this is starting roughly around the time of dinner or post dinner itself. So, and that has continued throughout the night. And out of 60 units of insulin, she's taking 16 units of glargine, which is not a huge dose. So therefore, in my strategy would be to work on the dinner time regular insulin. Probably she's taking more regular insulin than she needs for dinner. And for tackling the post breakfast high glucose followed by a steep low, that typically suggests that there is some problem with the timing of regular insulin and the time when the actual breakfast starts. Very often children in the rush to go to school, they just take regular insulin and start eating within 5 to 10 minutes. And that causes a post breakfast peak and followed by a delayed action of insulin, particularly with regular insulin, which causes a low blood glucose level. So here we have to ensure that about 30-40 minute time is given for regular insulin to act before she starts having breakfast. So this is just to illustrate that different devices or different websites give different kinds of output. So this is output of a 4-year-old boy with type 1 diabetes of 1.5 year duration who is on glargine and aspart. And this is generated through Tidepool. And you can see the summary statistics here on the right side. You can see that 49% is in range, that is 70 to 180. And the CV, that is coefficient of variation, is high, that is 53%. As you can also see that there is high variability, particularly in the night and between 12 to 3 p.m. Now, when we see, I'm not interpreting the whole CGM for this particular case, but when we see this CGM, you can see that the blood glucose is rising. It is very high in the later half of the night, that is 3 a.m. to 6 a.m. And this is starting to rise after 12 o'clock. And if the child is having dinner at 7 or 8 o'clock, it is unlikely that this is being caused by the aspart. So most likely, since the glargine is being given in the morning, the effect is not lasting for 24 hours. Most likely, that is the reason. And we can confirm if many daily curves show a pattern like this, where there was a normal or relatively okay glucose in the first half, but in the second half, the blood glucose values are rising. So either it suggests that there is inadequate glargine dose or the effect is not lasting for 24 hours. So the solution will be either to split the dose or to change to a ultra long acting insulin like Degludec. CGM can also be helpful to educate families on pre-mixed insulin. Some of them are already started on pre-mixed and they are unwilling to change to basal bolus. So we can take the help of this visual analysis, which shows very high values post breakfast and lunch not being covered with insulin, and then a steep drop, which means that if we try and correct the high glucose post breakfast, there is a high risk of hypoglycemia in the later part of the evening. So this can be helpful in educating the families. Also, it can be extremely helpful to educate on the effect of different food items. So in this particular boy, 7-year-old, you can see that there is a huge variability between 12 o'clock to 8 o'clock. And when we see the diet record, we can see that he's had golgappa, chola kulcha, bread sandwich, snack packet, biscuit packet, momos, kurkure, and Maggie one on each day. And it was so useful to just show this to the mother and father about what impact it has had and what a prolonged impact these things have had on the blood glucose values. Lastly, CGM can also get integrated with pump when we are using a compatible CGM device. Although this is not an AGP kind of output, this is a Medtronic CGM, which is giving, again, median glucose as a dotted line. And these are like individual day curves, and the high and low glucose values have been highlighted as yellow and red. And it also integrates the basal and bolus doses that we are giving. And it does give daily curves, and we can see that in many days, there have been plenty of correction doses that have been taken. Either it suggests that there are problems with insulin carb calculations, or it might also suggest inadequate basal in the daytime. So this is how CGM can be helpful in better management of people using insulin pump. So to end my talk, I would give some key messages, namely that CGM is a valuable tool and it gives information beyond HbA1c, which it turns out that it does have a lot of implications with respect to complications and other outcomes. The important educational tool also, it gives a very nice visual analysis. There is improvement in glycemic outcomes and severe hypoglycemia with sustained use. All the devices should generate the report as an ambulatory glucose profile. And at least 10 days data should be available to make meaningful predictions of 3 months of outcome. We should follow stepwise interpretation of AGP, which can help in better planning of diabetes care. Thank you so much for your patient listening.